about 2 years now as the chief here, and I don't know. This is something that obviously across the nation everybody is very passionate about because it absolutely has nothing to do with law enforcement. This is not the response to mental health. Homelessness is not a police issue necessarily, and I think everyone in this room will agree with me, as everyone has across the nation, an expectation of us creating something with partners. So, go for it.
Yeah, I'm Ryan Carruthers, Chief Clinical Officer with CenterPointe, and have been with the agency for about 6.5 years. And so I oversee all the various clinical programs and try to help facilitate our community partnerships with LPD, with other organizations as well. Lincoln, Lancaster County, for that one out.
And then I'm Amber Dirks. I'm also with CenterPointe, and I'm the Senior Director of Community Response. So I have been there for 3 years, 5 years if you count when I was at Touchstone, which is a partnership with CenterPointe and Houses of Hope. So I directly oversee our crisis response programming, and then I oversee our Link Point programming, which is also a partnership with law enforcement as far as civil protective custody. And then I supervise leadership for our street outreach team, who works with the unsheltered population, and then our Cure Act team. So I kind of oversee all that stuff, really focus on that development and expansion of the community partnerships and everything that really happens in the community with individuals experiencing substance use, mental health, and homelessness.
So I think the idea is we're going to talk a little bit about what CenterPointe does, just to set the groundwork for a budding co-response partnership. At CenterPointe, we have over 40 different behavioral health and social service adjunct programs between Lincoln, primarily in Lincoln, have a near full continuum of care in Lincoln, along with several programs in Omaha. Our mission is to help the people we serve get better sooner for longer. Very straightforward, just here to try to serve people that are in need, without pretext of what kind of need that is, just trying to identify what those needs are and help them to achieve them. So we've developed really what we call our model of care as it relates to co-response. Some of the key things are the housing first, harm reduction approach, which really says that in order for us to work with people, we should not put barriers onto them that make them less likely to receive help. Know that the whole idea of working with people with very complex needs, especially when they're in crisis, is that you can't say you have to do this or we're not going to work with you. Those external requirements. One of the traditional requirements for housing programs, for instance, is a requirement to be abstinent or seeking abstinence or in some type of active recovery program. And what we found is just putting that in means there's a whole group of people that will just never seek the housing. Not that they don't want housing, they won't seek it because of those requirements you put on it. That also includes for shelter, the same kind of issue can come up. So we believe and practice this housing first harm reduction approach. And harm reduction, if you're not familiar with that terminology, just means that we're going to meet people where they are at. We're not going to leave them there. We're going to meet them where they're at. And whether that's them experiencing homelessness, them being under the influence of substances, we're going to meet them there. We're going to take a non-judgmental approach. And then we're not going to set a goal for them of that end goal of them, say, abstaining from drugs. We believe in common sense approaches like a syringe service program, which is not legal in the state of Nebraska, because if our organization were to hand out syringes, we would be guilty of a felony for handing out clean syringes. Only a pharmacy can do that in the state of Nebraska, and no pharmacies actively do that in the state of Nebraska. So we believe in those types of things and try to advocate for a approach that just makes sense for identifying what someone's needs are. Evidence-based practices, I know these two are going to be speaking a lot about what the growing evidence base is surrounding a co-response model and how to take this burden off of police departments across the country and put it into the people that are trained and specialize in helping people experiencing homelessness and those with mental health issues. And then data-informed decisions. So we really believe that you have to be able to show what it is you're doing and provide that evidence. Evidence-based practices are based on data, and so those two really kind of go hand in hand. So that's really my part. I'm going to hand it over to Amber. Oh, okay. So we are, we are a certified community behavioral health clinic as well. And there are now numerous CCBHCs here in Nebraska, 2 here in Lincoln, CenterPointe and Lutheran Family Services. And basically what that says is that we're able to serve anyone regardless of ability to pay, insurance, anything, regardless of a legal status in the United States, that we don't have any means of turning someone away. The only reason someone would not be able to get service is if that service is full for that day, and then it would be, hey, we can't today, come back tomorrow, and we'll get you that service tomorrow. One exciting thing that is going on, the governor just signed into legislation a bill that has the state of Nebraska moving forward with Medicaid paying for this CCBHC legislation. Or for CCBHC services. And so that's something that will be expanding further and further throughout the state of Nebraska in the coming years.
And kind of to go with that, so that's what started, so CenterPointe had crisis response before CCBHC. They had a 24-hour crisis line, they had walk-ins, and then they did systems of care, which was more of the youth response in the community with law enforcement. So with this grant, we were able to bring on my position as the Director of Crisis Response in 2020, but then it also allowed for us to add more therapists to the team. It allowed for us to add peer support specialists, so individuals with lived experience. And then as we actually got another grant, which I'll talk about in a couple more slides, it expanded our team even more to be able to add youth and family specific services with another care manager and youth and family peer support. So our team actually is comprised of lots of different perspectives, lots of different education levels, experiences, and then we also have crisis team members, which really is bachelor level employees that have experience within this field, whether that's social work, psychology, criminal justice, that can also do all the crisis work in the field. Part of this expansion has also been really focusing on the expansion of partnerships, one of the biggest ones being with law enforcement, and really being able to identify what their needs were, what the individuals in the community needed, and how we can respond better to mental health crisis. We also focused on partnerships with Bryan Hospital. That was one that had also kind of been something they wanted to expand, but it never really took off, so we were able to expand that as well. And then we've also continued to expand with other community partners, Mental Health Association, TASC, the region, and all of that as well. So a big piece with the expansion is our 24/7 mobile crisis response. So like I said, we had systems of care in place before that, where it was only law enforcement, it was only for youth and families experiencing crisis. With this expansion, we were able to expand that out to the adult population and be able to respond to crisis for law enforcement. We also respond for the hospital if need be. We can go there. If somebody goes, they don't get admitted, we can go to the hospital and do that as well. So that was a big part of this expansion too. Our 24/7 crisis line, so we have always had that, and it was just something that we continue to do. Walk-in services at campus for health and well-being. So that is our new location at 2202 South 11th Street. But Monday through Friday, 8 to 5, we have walk-in services. we always say crisis is identified by the individual. So when we think about crisis throughout this entire presentation, that doesn't mean that somebody has to be experiencing suicidal thoughts to meet with somebody in crisis. It's really identified by the individual. We're very person-centered, focusing on what that individual's needs are in that moment. Really focusing on that crisis stabilization, helping kind of stabilize in that moment, and then figure out how do we get you to that next level of care that you need, how do we get your needs met and get you supports in place. Another piece that has also expanded is, Ryan kind of touched on our philosophy behind harm reduction, but also having harm reduction outreach programming. So if somebody, law enforcement, Bryan Hospital, it can be self-referral, but somebody reaches out to us because they experienced an overdose, they can get a referral out to us, and either the crisis response team or our street outreach team tries to engage those individuals. We try to get them access to Narcan, maybe get them out to outpatient to get an assessment to be able to get into services and do those referrals for them as well. So I kind of touched on this already, but with youth crisis response, we got a grant that was with the Lancaster County that allowed us to, again, expand crisis programming. We added that peer and care manager. This really focused on, again, partnerships with Lincoln Police Department, but then also other youth programming. So Child Advocacy Center, Lincoln Public Schools, Bryan Hospital, and Cedars. So what all do you know about those programs, or like what resources there are for youth in the community experiencing maybe some sort of crisis, suicide, law enforcement contacts? What's your knowledge about that stuff? Or experience with that?
I work at Cedars, so I know all about that one. Child Advocacy Center we partner with a lot as well.
Yeah. So one thing that we were experiencing is that these kids that are experiencing crisis, whether that's, again, maybe they're having problems in school, they're experiencing mental health crisis, they're experiencing suicide, is that they sometimes feel like they don't have a place to go. Maybe the resources aren't available. Maybe they went to the hospital, but they weren't able to be admitted because they didn't meet the criteria. So then they're kind of feeling like they're stuck in this place of, what do I do? So that was part of this partnership expansion, is that we worked with Bryan's mental health youth programming to be able to go there, meet with families and youth that were being discharged that maybe needed some ongoing support, that needed to get into services. So I would say crisis is kind of, we've become kind of that bridge as well. So crisis stabilization, but also that bridge to help people go from their crisis they're experiencing and stabilization to maybe getting to that next level. So we really kind of bridged for a lot of different agencies, but also within internal programs as well. An example of even with that expanded partnership is we had a field response that was with Child Advocacy Center and law enforcement. They were working with a youth who was had an active case. There was a notification of death that had to be done with that family. So they actually called out our crisis response team. So one of our crisis therapists went out there to meet with the youth, the guardian, the Child Advocacy Center worker, and the law enforcement officer to do that notification of death, but also provide support, coping, help them get the resources that they need. And because of our Lancaster grant, we were also able to provide shelter for the animals during the interim when they had to get a hotel to stay at. So that was the way that this partnership and kind of that idea of what our kind of co-response has been to this point. And then also with Lincoln Public Schools, there's been a huge expansion with that. A lot of times it is going to be youth that are experiencing suicide. They refer them to us. We'll meet with them on a walk-in basis to be able to assess for safety. We do a risk assessment with them. We do counseling on access to lethal means and safety planning with those youths to be able to get them prepared to go back into the school environment. These are just some numbers based on our fiscal year for I have it broken down by adult crisis line, adult walk-ins, youth crisis, and youth walk-ins. So the first year that we started to expand things, and during COVID our crisis calls were up. The next year it went down a little bit, and then this last fiscal year it's about to where it was during COVID. Our adult walk-ins were less during COVID, went up, and we saw a slight decrease in that. Youth crisis calls have gone up overall. Again, I think it's just with those expanded partnerships and then being able to let people know about our crisis line, and then with our walk-ins, we're at 78 for this fiscal year thus far. We still probably about, I think he did it through beginning of May, so we still got 2 months of data to add to that once the end of the fiscal year comes.
Did you break that down by age as well?
Yeah, yep, we are. We have an amazing person that does all of our data, and he can pull all that information and get us like broken down by age.
Do you know just offhand what the highest age that you've seen? The highest numbers in what age group?
Yeah, 'cause I think we've had as young as 8. I think a lot of them are like that 9 to 14 range seems to be a lot of our population that we're seeing for those walk-ins. Yep.
And this is just CenterPointe data.
Yes, this is
This is
CenterPointe
not
specific.
law enforcement even. I mean, and these numbers are huge when you actually start thinking about it.
Yeah, because we do have some, like we've also, with a lot of our trainings with law enforcement too, they can also bring people to us, but it may not say that it was initiated by law enforcement at that point. So some of these may have been ones that law enforcement brought them to us to meet with us, but it's not maybe reflected in that because it wasn't actually being called out to the community. So as far as our mobile crisis response model, so we've kind of developed it, so we've changed and developed the system based on kind of what we've seen with what worked and didn't work. So we've actually changed it to where we provide dispatch and on-call schedule each month. So everybody on our team has rotating on-call. They each have a specific crisis phone. So on-call or dispatch actually gets that. So let's say if law enforcement's out in the community and they want somebody to come out, they call channel 16, they get the number for crisis response, whoever's on call, they call them directly. It takes out a bunch of middle people trying to get all the details and relay that. They get to call our on-call directly. Our response time is approximately 20 minutes, and we have been able to, stay within that time frame. Middle of the night it might vary a little bit, but for the most part, we have about a 20-minute response time. So when we go, when we get there, we're gonna talk to law enforcement, identify, so they're gonna give us basic details before we get there. When we get there, we're gonna talk to them, they're gonna probably introduce us to the individual. We're gonna ask if there's any concerns for our safety, any weapons, anything like that. At that point, if there's nothing as far as safety concerns, the individual's willing to meet with us, law enforcement gets to go back into service, and we continue to meet with the individual and do everything that we would at a walk-in. So we're gonna screen for suicide, we're gonna do risk assessment as needed, again, counseling on access to lethal means and safety planning. Obviously, part of that too is gonna be identifying really what brought law enforcement there. What was it that they were experiencing that they felt like they needed some more support? So we will also, do coping, support, resources, and then attempt to coordinate any follow-up and ongoing services. So ideally, we should have a follow-up with anybody that we have a face-to-face contact with within 24 hours, checking in, seeing if that safety plan is still working, if they want any ongoing follow-up. If they do, we will continue to engage with them for 7 to 30 days. Again, with the goal being, how can we get you into the next level of care? What kind of supports do you need? Does anything need to change with your safety plan? So we'll continue to work with them for that period of time. And then we also communicate a lot with, Lincoln Police Department does have a mental health liaison. So anytime we go on to a field call, we will also then send an email to their mental health liaison just saying, this is who dispatched us out, this is the time, this is when we arrived, this is when we left. Here is the outcome of what happened from that, and here's our plan moving forward. So here's some data. So the first year when we first really rolled it out, I kind of noticed with the trends is when we talk about it, we see it increase the numbers, and then it kind of maybe falls down a little bit. We talk about it again, it increases again, so on and so forth. So the first year we did have 62 initiated by law enforcement. The number of people that stayed in the community was 55. So 88.7% of individuals that we went out for mobile crisis response were able to stay in their community placement, and then we were able to continue working with them to get appropriate level of care that they needed. 2021 to 2022, there was 55 mobile crisis response calls that were initiated into the community. 42 of those stayed in the community, and 82.4% stayed in the community. We do also have volunteer number that voluntarily chose for the hospital. So if we go there, I mean, we are very, again, harm reduction, we're person-centered. Our goal is to keep people in their community placement. Even if you're saying, I'm experiencing thoughts of suicide, I would maybe do it this way. But if you're willing to restrict access, you're willing to safety plan, we're gonna have you stay in the community, and then we're gonna figure out when do we need to follow up with you. 24 hours, if they say I can stay safe for 4, we'll check in with you in 4 hours to see how you're doing if something needs to change. So, ideally, we want to continue to have that number of the hospitalizations being pretty low. And then, to date, we have had 51 initiated by law enforcement. I know in the last probably month, we've already had 5 or 6 more just this month. So we've already seen an increase again this month of how many we've had, with our rate of 84.3% being able to stay in the community.
Can I ask a quick question
Yeah.
on this slide? The number that were arrested jumped from 0.0 to 3.9. Was that just because of the additional co-responsiveness like you mentioned earlier, or probably just like more
Yeah,
people being seen, or?
I'm guessing, and sometimes too, it's, they also try to be like, let's try this option first, and then if they, let's say, become aggressive or threatening, and then at that point the safety is a concern, then that's when they would,
Sure.
go for the arrest option. Any other questions on it? Just the CenterPointe specific stuff and how we're doing things up to this point.
All right, so you saw the first basically phase, right? So we've been doing this for a number of years, huge partner for us. And what's been built is the officers trust CenterPointe and the teams that go out. We have a lot of incredible partners like Cedars for youth and other organizations that we depend on. Coming from another city, it is impressive that everyone gets along. Trust me, gets along. It's hard to say that happens in other cities, because the goal ultimately is some people don't belong in jail, some people don't belong in the hospital, and if we can get people down here before they go up here, that's the goal. That is the ultimate goal. So when we looked at the model for the next phase, I don't know if this is gonna, oh, it did work, sorry.
Just holding out the whole time.
Well, I didn't want to like test it while you guys are talking, because that would have been awkward, right? So what is meant by co-responder? So a trained professional team embedded within the police department to respond to mental health calls for service, or work closely with community care providers for those with behavioral health concerns. These dedicated team members are police officers and mental health professionals. The goal is to improve the outcomes of individuals in crisis by providing effective crisis de-escalation and connection to behavioral health services. Now, we've gone to many different places, had long conversations with other jurisdictions. We wanted to know the positives and negatives of what they've done. We know that what we're doing currently is positive, but what we felt that they weren't really focusing on was, one, data. We asked for data and it just wasn't happening. And the other thing is the division between homelessness and youth mental health. They all coincide together, but many people's models only talk about adult mental health. Well, adult mental health and then youth mental health are two very different things. And so in our model, what we want to do, this is really handy. What we want to do, so we build research-based principles and practices, Bureau of Justice Assistance funding, technical assistance. IACP is an organization that all law enforcement can go to. They do a lot of great research. They're very dedicated to co-responder model and really bringing law enforcement profession up to a higher level than what we've been before. University of Cincinnati is one of our partners right now. Cahoots helped us overall. When prior to me coming here, we engaged them to look at what we do today, give us their best guess. And then we visited Houston, Portland, Maine, Denver, and Salt Lake City. So this is what the team structure is going to look like. Let me just first say that the importance of having a relationship with the team and law enforcement and community are essential in this being successful. So we're always talking about that. So there's gonna be a supervisor, that's gonna oversee the civilian side of it, but also we'll have law enforcement having a supervisor as well. My goal is to have whoever that supervisor is. See, this doesn't have a light, or I can point it. We'll build the program. And what I want to hear from people that are building, especially on the civilian side and the law enforcement side, is what is best for Lincoln, Nebraska. We're not building for Omaha, Nebraska. We're building for Lincoln, Nebraska, because we're better than Omaha. Anyone from Omaha? We're better than Omaha. And so what we want to do is have a supervisor. It'll be under Operations Bureau, which is patrol, and then civilian clinician coordinator, 2 civilian liaisons, crisis responders, and then 2 police officer liaisons. And what we want to focus on with the police officers is they're focused on the mental health, youth mental health, and then homeless. So currently, Melissa Ripley is our homeless mental health liaison. She sits on the Homeless Coalition Board, has a ton of experience. No one can tell me, I have a little bit of experience being from San Francisco, that homelessness, mental health, drugs do not coexist. They do. And so we need to attack it that way. The fact of the matter is, do we have a ton of homeless? We don't have a lot of homeless that you see on the street. We have a lot of homeless that are on people's couches, sleeping in the cars. And we need to address that the best that we can. And so I'm hoping that this team that will go out together, but also train together, because a lot of people don't want law enforcement involved at all. They will not be in uniform. But they will train together. There's a huge safety factor in this. There's no way I'm sending civilians out to go to calls for service by themselves. Because you never know, things change just like that. And if I could show it to you, I would, but I can't, because you have to go out and do the job to understand what I'm talking about. I don't want anyone getting hurt. And so that coexistence and understanding and respect for each other, when somebody should step up, when someone should step back, if you don't have that relationship, is critical. And so them getting to know each other is the most important part. So on the civilian side, community crisis coordinator, our goal is to have a licensed mental health practitioner with experience, oversee coordination with the Lincoln Police Department. Data collection is so important for me because it justifies if we're being successful. I mean, and I have to say to the public, we are being successful, and they're going to say, well, how do you know? What's the measurement? You know, respond to calls as needed, so they'll have radios and they'll respond to calls. Officers will call them. It'll be a natural progression for people. If we have a barricaded suspect, we're going to call the team. Because if it's not working for us, we want to de-escalate, and we want to bring it to this level where somebody can be talked out, of wherever they are. Community crisis adult liaison, serve as first responder for adults, provide follow-up and case management, partner with community agencies. And you'll see a slide about what's unique about this program, and I'll get more into it, but community crisis youth liaison, again, first responder, follow-up case management, partner with Lincoln Public Schools. We have a great relationship with Lincoln Public Schools. We have great SROs that work very closely with schools, great relationship, and they're very proactive. So the training, officers currently trained in Beta. How many people know Beta? It's a threat assessment tool that our officers learn how to use. But for us, what I've committed to is training all of our officers in crisis intervention training. Most departments have about 30% trained in CIT. I believe that we should have 100%. But it's really finding the right training. Because I could just bring in one day and say everyone's trained. But I just don't work like that. I came from a program that actually was very good. Scenario-based, everyone understood it, they practiced it, and they went out and did it. LPD committed to CIT. Dispatchers are the huge key to all of this. So people will call 911, they have to ask the right questions. So we can figure out who's going to respond. And those questions will tell us whether or not there's a violent situation, or can this team go out, maybe with one uniform, but can they go out by themselves? You know, those are things that we have to always like figure out. And they also have to be comfortable with it too. Responding to calls for service is not easy. The unknown of every single call. Just imagine someone calls you and you have to go to someplace completely foreign to you to deal with the situation that someone calls. So it's very difficult, and we know how to do it as law enforcement because we do it every single day, but the team has to get used to it. Homeless outreach, again, it's really important that we understand who we are speaking to. The idea for me is, with the case management especially, is we get people down here before they get up here. Because that's what happens. In let's say every police shooting, where you're gonna hear from the family is, yeah, they had a problem for weeks, if not months. We haven't spoken to that person for maybe a year. We couldn't deal with them. So here's the thing, we know when people get up to here as law enforcement. Families don't have the tools. But with this, can we get in with the family as well, and they call us and say when someone is now getting to that level again? Because a lot of times, you mix mental health and drugs, that's where the violence comes in. And I can tell you story after story. But it really is coming in at a level that we can manage it and stop it before it gets to be up here and anyone gets hurt. Because it doesn't have to happen. And get them the right, you know, they need to get to get help. I mean, that's the idea overall. So dedicated commission officer liaison. Identify unsheltered through street outreach, calls for service. And so again, it's going to be not only the team, but the other members of CenterPointe, but also our great relationship with the Mission and Matt Talbot and Cedars. I mean, all that we have to communicate. It's going to be ongoing. The minute that we don't have that relationship is when we're going to start failing. And that's what we're not going to do further. Connected community coordinated entry to obtain shelter, coordinate with service providers, connect with people where they are to reduce the need for officers' response to unhoused and mental health calls for service. Any questions so far? Barney. Barney has a hairball. Yeah. So observation for services tool is something that, I took this out, is something that we started 4 months ago?
The pilot was released in November
Yeah.
last year. We
Time
started in
is
April.
flying.
working on it.
So Roy Rivera is my assistant, executive assistant, who, we started this program, basically I was at a mayor's conference with our mayor, and someone brought up, well, officers can observe more, but they don't have the tools to help the family necessarily. And that made me remember when I was a very young officer in '95, it's a long time ago, that's what you do. You go into these situations and you see there's no food. You see that the kids need clothes. You see that the parents need help. Well, through this, the officers are able to, that is his daughter, by the way. Love that picture. They're able to go in the car and there's a mask in which an officer can just check. Just make a check, and then Roy will take that, and because of our partnerships, we're able to then give the information to them for them to then take and help the family. And it's actually, I mean, it's worked pretty well. We just rolled it out to all the teams as well as our investigative teams for them to use it. And so we're hoping for great things for it. I mean, it really is important to empower the officers to feel like they can do something different instead of just going to polls or just arresting people. It's so much more deeper than that. Collaboration. This model would not be possible without a robust collaborative, I can't talk anymore, collaborative with all partners, agencies, and organizations. The city and the county are fully committed to this. Fully committed. to make sure this is up and running. And on top of that, you know, we're not afraid to change it. If it's not working, we have to be flexible, we have to be able to talk about it and maybe change it so it can be for Lincoln, Nebraska. Why is this program unique? Collaboration with established longtime partners allows for a more seamless transition into the program. Trust between law enforcement and care providers, we build more and more. Law enforcement can break that relationship and trust within seconds. Whether the media is reporting something, or you see something on social media, or we have to be in an officer-involved situation where somebody can get seriously injured or pass. Use of force is never pretty. I don't care what level. I've never seen anything that looks good, okay? It just is. And so, unfortunately, we're put in those positions in which we have to react. But, you know, the thing is that it's about these relationships that we can constantly work on and constantly build in order to have these ongoing conversations. So those relationships are essential. Homeless liaison, common vision on intersectionality, holds position on the Homeless Coalition Board, which is what Officer Ripley is, and we're really thankful that she can actually give us all her experience. Youth mental health liaison. So this is why this has been a huge thing for us in conversation and a priority. If we can, so we're really dividing into different sections, right? We're saying we need to deal with adults that have these issues. But what we're saying is that we don't want youth to become the adults with these issues. And so we believe, and this is a longer look at this, we believe that if we can get in early with the youth, that they won't have to deal with what adults deal with today. Because they're gonna have all the resources, everything that they need. And so hopefully we'll be able to intervene earlier in life so that it doesn't become a problem later in life. That's the idea. Work with the Lincoln Public Schools, who are great partners, school counselors, care providers, and families. The families need an outlet. They do. They don't know what to do. Either they're embarrassed or they just don't know. They don't know who to call. They're at their wit's end. They might have more than one kid that is difficult for them to only focus on one. And then we have the population refugees that don't even understand the system. And so those are very important for this program. And then this horrible looking picture over here. This is all our information. We can answer any questions that you might have, unless you guys want to add something additionally to this.
The only thing I was going to say is when you look at the collaboration piece, and back when we went to the data, we had the 51 responses, you know, thus far this fiscal year. I think if we're at 51 when it's more of a, you know, external, like we collaborate, but it's external, and we had, what was it, 84% of the individuals that were staying in the community. Imagine how many more people that we can actually respond to, assist with mental, you know, assist with mental health crisis, the homelessness crisis, substance use, whatever that crisis is, how many more people can stay in their community placement and actually get the supports that they need versus having to go to the hospital, you know, and again, racking up more financial stress maybe, or going to the crisis center, or continuing to experience ongoing crisis because they can't get that support. So I think that's the one cool thing that I think is really going to be big about this collaboration or continued expansion, because we've been doing a lot of these things. It's now just let's make it more embedded, expand it more, be able to touch more people and to impact more people, and hopefully, again, keep more people in their community placement versus these control settings, or, you know, even jail. I didn't mention jail, but you know, like even jail. So trying to keep more individuals in the community and getting the supports that they need that are going to be more effective long term for them and for the system itself too. So
we try not to put people in jail. I mean, we really don't want to, especially when we talk about things like DUI or being drunk in public under the influence. The only people that really do go into jail that are in those situations are people that are being violent. And a lot of times, sometimes, and this is hard to understand since society is saying, you know, we need to stop putting people in jail. Sometimes a timeout actually is helpful. And we can have these conversations with them when they're off of whatever they're on. And so it's not ideal, it absolutely is not, but sometimes we have to do that for the safety of people that are doing the work. We do have a location where we take people that are under the influence or DUIs. I'll tell you, when I got here and I heard that the drinking and driving, don't go to jail, I'm like, what the hell are you guys talking about? Because that was so foreign to me. Because if you're under the influence, you go to jail. You go straight to jail. And so, but here we don't, and I really bought into it because we don't need to do that. Because when you go to jail, you go into a cement room, or if you're not behaving, the sheriff's department will decide whether or not you're going to be stripped and thrown into what we call a rubber room. That's not acceptable to me. People make mistakes, but it doesn't mean that they have to be punished to that level. They're already being punished by being caught and having to go through a system and having to call their loved ones. I mean, that for me is it's hard. It's hard for people. But I've totally bought into the system. I believe it works. But just understand that we really do try not to go that direction. Our officers do everything they can. They'll call family members for them to come and get the individual. So they don't even have to go to our facility or go to jail. Majority of our people, a loved one will come and get them. And that's important because it's about respect and it's about the fact that they made a mistake and that they have to pay for it, but they don't have to, not to that level. Does that make sense? Anyways, I'm gonna stop talking. Do you want?
Yeah, I was just gonna throw out, I was giving Chief Ewens a hard time because these were being given away downstairs, and so I was like gonna have her. No, in our minds we have this kind of preconceived notion about what law enforcement is, and sometimes on the behavioral health end, we see people who have experienced significant trauma because of their interaction with the justice system in general. Sometimes that's in police, and just want to say how wonderful it is. Lincoln, I live in Omaha. I worked most of my career in Omaha, and Lincoln is better than Omaha in terms of how agencies come together to work together to meet the needs of the community. It really is a more partnership friendly, all trying to help the community and the people in need environment, and that's not always the case, unfortunately, in Omaha. But as well, how wonderful it is to have the leadership of Chief Ewens. It's really pushing these initiatives forward. In June of 2020, it was one thing for people to say, hey, we're gonna make these changes in the system. Well, 3 years out, the fact that Lincoln is now being continued to be pushed forward from within, not even because of significant incidents of the community or anything like that. I think it really does say something to the true buy-in to this kind of a model and just meeting the needs of people and getting them into the services rather than over policing people that ultimately aren't a danger to society. So kudos to you and your leadership.
I paid him.
Not paid. But I'm gonna make her take these.
Any questions?
I'm just curious, I know CenterPointe's in Omaha too, will they be utilizing any of this?
Omaha's not allowed to come here.
Yeah.
I'm kidding.
In Omaha, our services are limited to 3 residential programs in Omaha. We are pending some grants for a CCBHC up there and would like to get more services going because we do believe that the model of harm reduction is very needed. Here in Lincoln, it's much more acceptable to talk about harm reduction than it is in Omaha. There's still a lot more stigma associated with harm reduction and all that in Omaha for whatever reason that is.
This is really good.
I think when everyone in this room starts talking about harm reduction and what that actually means, as opposed to what the news or some politician that is wooing about how horrible it is. I was the captain at 1001 Station, and for many of you, if you don't know San Francisco, it's one of the most inundated areas for use and mental health issues. And so harm reduction does work, because it is, if you talk to anybody that's trying to go through recovery, it takes at least 5 times for them to go into a program, right, Brian? And it takes away the stigma if we start talking about it and understanding what it actually means. Because I'm gonna tell you, my time over there, we got a lot of people from the Midwest. A lot of families sent their kids to go to recovery in the Tenderloin. I can't tell you how many conversations I had with kids. And that's unacceptable. It has to come from here, and we have to stop pretending like it doesn't exist. You know, it's in every family, mental health, drug, some kind of addiction, you know, stop pretending it doesn't exist. And so we have to start breaking down those barriers, and obviously, we have a lot of work to do. But it's the conversations that everybody in this room has that's gonna make the difference.
So I am also a California transplant, and
Oh, where?
so Bakersfield.
Okay, great. My brother lives in Fresno.
You can say the whoa like everybody does because
Yeah.
of Bakersfield. But you know, in California, like it's 2 ends of the spectrum. That one where homelessness is so prevalent
Yeah.
that it's all people talk about, and it's like you almost become desensitized to it. That there's just not even like I don't know. It's just so you're inundated with it. But then you come to Nebraska and it's almost like, oh, we don't have homelessness in Nebraska. Like homelessness doesn't exist here. There's no homeless people in Nebraska. So how do you, in Nebraska, have those conversations when people aren't even really, or like the general public especially, just isn't really willing to recognize the homeless population? And I know you said it before of like, we don't deal to the extent of like, they're sleeping on the streets typically, but how do you start even a conversation of that?
Well, my conversation is gonna be different from their conversations.
Yeah.
Because, they're asking me as if I'm gonna vilify it. I'm not going to. I think that what we don't realize is how many people actually are sleeping in their cars, how many people are close to losing their cars, and then how many people are also sleeping on friends' couches. We have to, you know, having that conversation is me basically saying to them, for my 28 years in law enforcement, homelessness is not really the problem. It's addiction, mental health, people have no place to go, they don't know who to go to, and it's not safe. So that would be my conversation. But convincing people in Central California is almost impossible.
Mm-hmm.
You know, Central California is like very conservative. Then you have the coast, it's very different. But it's a hard conversation depending where you are. And it is a hard conversation here because it's an excuse to not do things. And it takes money to take care of this issue, and it takes a lot of people to help. And they don't wanna commit to that. I think Lincoln is very unique in having the city and the county, and the mayor this was her #1 priority when I got here. So, and I know the county also feels the same way, is that we have to do something because our city is growing, a lot of services are here, we have to be able to answer the call when we're asked to.
I think too, a big piece of it is just more education for the community as a whole when it comes to like decreasing the stigma, and just, cause I think so many times it's this idea of, well, they just don't wanna get a job, or they just don't, like there's so much stigma behind it, so I think a lot of it too is really just educating people, and I think part of the corresponder piece too is, you know, getting that buy-in from the community, really educating the community about mental health, about substance use, about homelessness, and again, trying to really decrease that stigma, because I mean, I come from a smaller community, and you know, those smaller communities, a lot of it, you know, there is so much stigma around that, and just that lack of understanding, and you don't talk about things, and so I think really trying to, when I think about homelessness or, you know, mental health as a whole, I think really just trying to educate people a lot more and help them to understand the reality and decrease that stigma for people, so they can get help, and so they can talk about it, and they don't have to feel like they can't seek the support that they need.
I think one of the easiest things to, in our day-to-day life that we can all do as, you know, if we're the choir, I can't sing, but, if we're the choir and we're the preachers, you're the choir, I don't have to sing. If you're the choir that we're preaching to and you already believe in it, the day-to-day action that probably has the most power and is the easiest to implement is being very intentional about how we speak about these things and encouraging others to do the same. And so moving away from homeless people to people experiencing homelessness, right? Substance abusers, moving away from that terminology into people who are struggling with substance use, people who are struggling with addiction, people who are experiencing mental health, that person-first language, emphasizing their humanity, their personhood, and then, all three of us do a lot of media. Whenever we at CenterPointe do media, we ask the media outlets to only utilize that language, so that as messages go out, they're going out in a way that doesn't, because so often the media, like we'll have a conversation with the media, their heart is coming from, they want to get the word out, and then they go on TV and use this stigmatizing language that doesn't help, right? And so, that's just one really easy implementable thing, just, person-first language, a person who's struggling with or experiencing this issue in their life. And encouraging humanity, encouraging people to connect with who it is that's actually experiencing this.
I'm just gonna, when I say that people went to San Francisco for recovery, they not only did that. What's happening right now in society with LGBT community, kids are gonna be flocking to cities like San Francisco. They don't have an addiction issue, they don't have a mental health issue. They're running away because they're afraid they're gonna get killed. Because I can tell you, I worked nights for a really long time, how much work I did in the Castro were these kids that ran away from their homes because they're LGBT, and they had to prostitute themselves. That's male and female. So that is a part of homelessness. People that are afraid to be themselves and they have to run away. It's not only about this. And when I say this, it's because every person can connect in some way. If anyone says, my family is perfect, and BS, that's just not true. You either have mental health, you have addiction, you have some, which I hate putting all of them together, LGBT, which is actually very, thank you very much. You do. But we're forcing people to run away, not have any way of sustaining themselves, and so they're forced to do things that they wouldn't normally do. And so I think, again, make it normal conversation. Everyone lives in a neighborhood. Are the kids really, are they okay? Because there's a lot on kids today. I didn't have this much stress as a kid at all. I'm grateful. My nephew is inundated with social media. He's a COVID kid for high school. And this is being recorded, which, sorry. And I really feel for them because they're gonna struggle and they're gonna use drugs more to help them cope. So we have to connect with the people that we know and we have to have these conversations. Now we got my soapbox. Barney? I need love. Any other questions? Okay, that was good. No other questions? All right, if you guys need anything, this is our information. You can absolutely ask me anything. I think all three of us are very much open to helping in any manner that we can. We will go anywhere and have conversations with people if that's what you wish for us to do. Because we actually are very passionate about what we're doing, and we feel very strongly about this. Hoping to get it up and running very, very soon, like yesterday, I wish. But yeah, just get hold of us. Right, are you ready? Let's go.